Hi, I'm Christian Müller from the University in Basel. I'm here at the ESC meeting in Barcelona 2014. I'm at the EHJ today, and I'm joined by Professor Steen Christensen from Denmark and Professor Juhani Knuti from Finland. These are the chairmen of the ESC guidelines on the perioperative non-cardiac surgery. These guidelines were published during this ESC 2014 meeting, and so it's my privilege to discuss with the two chairmen all the important news that these guidelines bring. So I'm particularly thankful for Steen that you were able to interrupt your intense preparation for the next skiing session and also able to come to Barcelona. So could you briefly highlight what are the major news that the new guidelines bring?
Thank you, Christian. Yes, for the last 1.5 years, a task force of around 25 people have worked on these guidelines. This has been done together with our anesthesiology colleagues. So it's a joint guideline with the European Society of Anesthesiology, and of course management of patients that are undergoing non-cardiac surgery is often a multidisciplinary thing, and we emphasize also in the guidelines that the more complex cases, we should really be a team of experts from surgery, anesthesiology, cardiology, and sometimes even also other specialities to try to discuss how we would give the best let's say the best possible management of the patients when they undergo surgery.
Mm-hmm. So Juhani, could you perhaps summarize what is new in the current document as compared to the previous document of guidelines?
There are actually a lot of new things. Actually, the whole guideline has been updated. If I summarize some of the main things, I would list maybe that first of all, the surgical risk has been updated completely because there are a lot of new things like endovascular surgery and such things which will have changed the whole thing about risk assessment of surgical risk. The second issue is related to estimating the risk of the patient. And there we have now included new indices which can be used to assess the risk preoperatively. Then one of the areas where major changes has been occurring are the specific comorbidities where, for example, heart failure, things, kidney disease, valvular disease, arrhythmias, and also many new areas have been included which were not there in the previous version. And maybe finally also the anesthesiology section was very much updated to include new neuraxial techniques and such things. So this is indeed a completely new guideline, but however we love to keep the stepwise approach which was there in the previous version simply because it's so helpful for the clinician who is taking care, and that makes the pocket guideline also working very nicely.
So among the assessment that is described in the guideline in detail, there are some steps to be taken prior to surgery, often in an outpatient basis, and then there's kind of the immediate assessment just prior to surgery. Could you just kind of give an example of patients, which kind of patients would require detailed cardiology testing prior to surgery? So let's say 2 weeks prior to planned surgery. What kind of patients should be scheduled for detailed cardiac workup prior to surgery?
Well, in fact, I think it's patients with fairly complex cardiac disease, because I think one of our major messages is also that actually many patients that are undergoing non-cardiac surgery can go straight forward and have the surgery without any further cardiac evaluation. But of course, if you have a complex cardiac disease, if you have a valve problem, if you have heart failure, or if you have extensive ischemia, if you have just stable angina, you would usually not really do a lot more. But if it gets into patients that are borderline unstable, that have extensive ischemia, then of course we will have to do a thorough cardiac evaluation before we recommend how and when the operation should take place.
So I think one topic that has received a little bit more attention recently is perioperative myocardial infarction. Could you just for the audience describe what is different from the clinic, our ability to clinically assess patients? What is different from the perioperative myocardial infarction, from the kind of regular myocardial infarction that may occur outside of the perioperative setting?
Yeah, well, I think the conventional myocardial infarction, if I can use that, is usually, of course, a thrombus in the coronary artery. But when you have a perioperative infarct, it's often stress on the heart due to maybe severe stenosis, blood loss, and other things. So we would have a type 2 or even a perioperative infarction that is different from what we usually treat. And this is of course a challenge, and we have also some risk reduction strategies that can be applied in these patients to try to prevent this. And in this particular area also there has been new recommendations regarding the use of beta blockers. We also have recommendations on statins and other vasodilatases, and I think in particular also new recommendations for the use of antiplatelet drugs and also for the anticoagulants. And there's in particular a fully new section on the new non-vitamin K anticoagulants, because of course in many patients these are now used, and I think many of us are not so used to handle these drugs, and I think it's very important that we have some clear advice on how we manage this when, for example, patients with reduced kidney function that are treated with these drugs are undergoing surgery. So we have tried to come with some good recommendations on this.
Perhaps to dig a little bit deeper on what you've mentioned. So Juhani, I think one area where physicians are particularly uncertain what is the best management strategy is regarding the use of beta blockers. So in the kind of the two scenarios perhaps that one could envision, the patient is already on a beta blocker and the other patient is not. Could you summarize what the current guidelines would recommend in either case, as continuing the beta blocker or reducing the dose or starting it new if it's not under chronic medication in this setting?
Yeah, this is one of the issues we have been working very carefully. Now, there are no major changes in stopping. So most of the recommendations in the past were also saying that if you are already on the beta blockers, there is clear indication not to stop it before the operation, because that may cause harm. So that is clear. Then there are certain situations when the beta blockers need to be started or are, so maybe saying, maybe considered. Now it's more soft than it was earlier. So it's less strong recommendations, but there are clear indications, like in heart failure. It is recommended that the patient should be well before the operation under beta blockers, as recommended by the heart failure guidelines. And also patients with ischemic heart disease, proven ischemia, it's known that these patients will benefit of beta blockers. But the starting in another groups of patients, it's rather a sort of a careful recommendation. You may consider in starting in the high-risk patients undergoing high-risk surgery. Yes. So that is the new thing in the beta blockers in summarizing things. Of course, there are some details like titration recommendation. You should not start them too close to operation, rather start it early and titrate slowly so that the situation is stable when you are going to non-cardiac surgery.
Yes, and also, for example, patients that are undergoing low-risk surgery, we do not recommend to start with beta blockers at all. So this section has been changed. For statins, we recommend that patients that already are on statins continue, and then we recommend that it should be considered in patients that are undergoing vascular surgery, but obviously most patients that undergo vascular surgery has an indication for statins anyway. And then, of course, as I said before, for the antiplatelets, since we now have a newer generation stents, as we call them, the recommendation of the duration of dual antiplatelet therapy, also in the new myocardial reverse guidelines published at the same time here, is now down to 6 months, not 12 months in the past. And of course, this also have implications for when we can undergo surgery if we have a problem and we have been stented recently.
So it has become a little bit easier if the duration of the dual antiplatelet is reduced.
Yes.
Okay, so perhaps as a last question, would each of you would like to kind of come up with one major recommendation or statement that you felt is of highest importance to the audience regarding this topic? So if you would have to pick one recommendation to our colleagues out of the recommendations that are in the booklet, which one would you like to choose, just to focus again on this?
Well, actually, I think I would like to emphasize the multidisciplinary approach and the team. You know, we have the heart team also in other situations. We should have something similar for the more complex situations and patients.
Okay, thank you, Steen. So, Juhani, what's your pick?
I think the best part of this guideline is really the very simple stepwise approach. And that has a power in that sense that it avoids a lot of unnecessary testing in most of the patients undergoing the non-cardiac surgery. So I like the whole story about these steps, which are of course based on large number of recommendations.
Great. Okay, so dear Juhani, dear Steen, thank you very much.
Thank you, Christian.
Thank you.